Tonight, we've already heard about a very clear introduction to lipids from a primary care perspective. And it's true to say that really from a secondary care perspective, it's very, very similar. And you'll see that we have pretty much the same guidelines that we will follow and the same approach to managing lipids. There'll be a few treatments that currently need to be started in secondary care or recommended in secondary care. And obviously we do see acute presentations much more commonly. But essentially the guidelines are the same. And Sue summarized many of the guidelines. And just to point out a couple, most of the recommendations from tonight and most of the recommendations that we offer come from the NICE lipid modification guideline. That's now being updated. So what we say tonight might change a little bit in the next few months. It will come out in the summer, but we've seen what's likely to be said. And there will be some changes, but at the moment, not too many. We've got the NICE guidelines for familial hypercholesterolemia. That's also quite old, but has been updated recently on the website. And as Sue has shown us, there's the Accelerated Access Collaborative Guideline, which is NICE approved. And that's really a very helpful tool in managing cholesterol and lipids. There's also an acute cardiovascular presentation pathway that the Innovation Agency have come up with. So again, not spending any time on this. Sue has shown this already, but this is the Accelerated Access Pathway, NICE approved, and it really covers primary prevention, secondary prevention, medications above and beyond statins, severe high cholesterol, and consideration of FH. And really, if there's any question that you have about management, this is a very, very good tool and useful tool. On the other side, which I think Sue showed you the effects of statins, it looks at a few other aspects, special patient populations, and it looks at some of special services and referrals and intolerance, but there is a special intolerance to statin pathway that Sue has shown you as well. This is the Innovation Agency lipid optimization pathway for acute presentations, and as you'll see in secondary prevention, we're managing people who've had ischemic strokes, acute coronary syndromes, and also peripheral vascular disease. And there are medications that we'll come to in timings, but usually when they present like this, it's an opportunity to get them on good secondary care medications. So as mentioned, I think it's still important for secondary care physicians to remember primary prevention. We'll see lots of patients, there's lots of risk factors, and we must remember things like the Q risk scores, and we should follow the guidelines. So the current guidelines, as Sue has mentioned, is that for patients or people with a QRIS2 score above 10%, they should be considered for statin therapy. We now have the QRIS3 score as well. Please consider FH or familial hypercholesterolemia in patients with cholesterols above 7.5 and even higher makes it more likely, but especially if there's a family history of premature cardiovascular disease. There are subgroups that we'll discuss, renal failure, diabetes, where there are other perhaps ways of managing. And as Sue has mentioned, in patients who've had events and for patients with FH, you don't use the QRIS2 score, you simply start treatment. It is important to say that we do have patients referred to us in the lipid clinic who've got other causes, and it might be nephrotic syndrome or alcohol use or medications or other conditions, and it's important to make sure we're not missing other medical diagnoses for their high lipid levels. Very important, as Sue has also mentioned, is that it's not just lipids on their own, it's risk factor management for patients and a holistic approach, and it's important when you're looking at lipids to think about smoking status, alcohol, blood pressure, obesity, exercise, all the other risk factors. We'd recommend a number of investigations, including renal function, liver function, measures of diabetes, thyroid function, and lifestyle changes. And this advice really should be for both primary and secondary prevention patients. So in primary prevention, all we need to really remember is after managing modifiable risk factors, after informed discussion, the medication to offer at the moment in the guidelines is atorvastatin 20. That's it really. You should measure the lipid profile again after 3 months, and the aim on the target is a reduction of non-HDL cholesterol of 40% or more from baseline. If that's not achieved, then a conversation about adherence, diet, lifestyle is important. And if it's not achieved for primary prevention, you can go up on the statin dose, you can think about rosuvastatin, and you can add in ezetimibe. And there should be ongoing adherence assessments with annual review. For diabetes, you still use the Q-risk score. And if it's above 10% over 10 years, for type 2 diabetes, again, offer atorvastatin 20. In type 1 diabetes, you really need to think of a reason why not to start atorvastatin 20. If they're more than 40, if they've had it for more than 10 years, if they've got nephropathy, if they've got any other risk factors, then you should start them on atorvastatin 20. You don't need to measure any Q-risk2 scores. Renal failure also puts you at risk of coronary disease and cardiovascular events, and anyone with renal dysfunction, you should start on a statin, atorvastatin 20, and again, the target's the same, which is a reduction in non-HDL cholesterol of 40% or more. So moving on to secondary prevention, again, the mainstay of therapy, and as Sue has clearly shown, is statins, and statins are key. They offer the best outcomes, the best reduction, are cost effective, and have a tremendous amount of data behind them. And the recommendation is clearly stated that for patients who've had an acute or established cardiovascular event, namely coronary heart disease, peripheral vascular disease, or ischemic stroke or TIA, you should address the modifier risk factors, but you should initiate treatment with atorvastatin 80. And if you are a secondary care physician and you're managing acute patients, they should be started on atorvastatin 80 within really 24 hours of admission, and the recommendation is therefore to test their lipid profile on admission. You can start lower if there's concerns about drug interactions, and you will need to check some drug interaction risks, and if we feel there's high risk of adverse event or patient preference. But certainly in our care for acute coronary syndromes, practically every patient will be discharged on atorvastatin 80 unless there's a good reason not to. As per primary prevention, you should reassess the lipid profile after 3 months and aim for this more than 40% reduction in non-HDL cholesterol. And I think, as Sue pointed out, this can be done in a non-fasting test. So non-HDL cholesterol can be measured in a non-fasting test. If targets are not reached, again, discuss adherence. This might be more at the GP at that stage. Lifestyle, perhaps increase the dose if you didn't start at 80. And then there are a multitude of other medications that we'll come to for secondary prevention that could be considered in addition to statins, sometimes instead of statins, and we'll go through that shortly. Before starting on a statin, please do ask if they already have generalized muscle aches, because then next week when they say they've got these muscle aches, they'll blame the statin. So it's worth asking. And if they do have such symptoms, measure the CK level. And that will tell you if there's muscle inflammation going on. And as long as the CK levels are not raised, it's safe to start statin therapy. And do mention, and I suppose it's Sue really to decide how much you mention, because there is a nocebo and a placebo effect, but there is a possibility in a small number of patients of getting muscle pains. Really, the story there is that the guidelines many years ago were to get people onto simvastatin 80, and that had a very high side effect profile. And atorvastatin 20 and atorvastatin 80 are very, very different. They don't have anything like that side effect profile. And unfortunately, bad decision making for cost-effective treatment maybe 15 years ago, 10 years ago, has led to some of this, but it's not really a real problem now, I would say. Statins are contraindicated in pregnancy, and so if pregnancies are planned, or if a patient becomes pregnant, then they should be stopped. So follow-up, as mentioned, we can measure a non-fasting lipid profile after 3 months. and we'd recommend an annual review, and usually that would be in primary care. As mentioned, don't measure CK levels routinely, but if muscle symptoms occur, it's very important to measure CK levels. With respect to liver function, that should be checked before starting statin therapy, and as long as their transaminases, so that's AST or ALT, are less than 3 times upper limit of normal, that should not exclude them from statin use. I would just mention to secondary care physicians that people coming with an acute heart attack will have raised abnormal LFTs apparently because of cardiac damage. So it's not a contraindication to statins in those circumstances, as long as it's due to the heart attack and not due to liver problems. If patients develop peripheral neuropathy, then we should stop the statins and seek advice. There are many alternatives to statins, but statins are really the primary, secondary, third and fourth line of therapy for cholesterol control. And the guidelines do tell us what we can use, what we can't use, what can be used in primary care, and as I'll mention, some things in secondary care. There's no real support anymore for nicotinic acid, for anion exchange resins, or omega-3 fatty acids routinely. Omega-3 can have a role in triglyceride, high levels of triglycerides. The guidelines are not to offer fibrates routinely. These are sometimes used in specialist lipid clinics, so there will be patients on fibrates and patients prescribed fibrates, but certainly they're not as beneficial as statins, and that should be first line. And there can be some issues adding them to statins, so they're certainly not routine fibrates. The next line really behind statins, with the longest history of use probably, is ezetimibe. And there are nice guidelines to support the use of ezetimibe. It works very well with statins. Statins reduce cholesterol production. Ezetimibe reduces cholesterol absorption from the stomach and the gut. And that way you together get a much better effect or synergistic effect than the two of them independently. It probably leads to about a 15 to 25% reduction in LDL cholesterol, a bit dependent on statin use or not. And certainly just showing one data slide, I've cut most of my data slides out. This was a study of about 600 people on atorvastatin 40, and in yellow, I think the mouse is working, in yellow, if you double up the atorvastatin from 40 to 80, there was about a 10% reduction in LDL cholesterol. But if you added ezetimibe 10 to atorvastatin 40, you got a 25% plus reduction. So if you're already on a statin, you're not doing well enough, adding ezetimibe can be very beneficial. More recently, approximately 18 months ago, bempedoic acid was approved. It works a little bit similarly to statins, and it does reduce cholesterol synthesis in the liver, lowering LDL cholesterol that way. It's only currently recommended with ezetimibe, and patients should not be on statins. So they have to be intolerant to statin, on ezetimibe, you're not hitting target, and then bempedoic acid can be added. And it gives about a 15 to 20% reduction in LDL cholesterol. So it's pretty good. It's not as good as statins. We move on to injectable therapy, and Sue has mentioned this. And towards the end of 2021, Inclisiran was approved by NICE. It's an injection, it's subcutaneous. It's generally given in GP surgeries. There may be ways of home delivery and self-delivery, and it's only given almost never. It's given initially, then after 3 months, then every 6 months. It's only needed to be given twice a year. And it works by interfering as an interfering RNA, preventing the production of PCSK9. This leads to more LDL receptors being produced by the liver on the surface of the liver, and that leads to cholesterol or LDL being taken into the liver and removed from the circulation. And there are clear guidelines for its use. It can only be given in secondary prevention, so not primary prevention. You have to already have tried statins and considered ezetimibe. And then if you've not hit target, or if they're not tolerating those agents, and the LDL cholesterol is raised, and you do need a fasting test really to measure LDL cholesterol, then you can start Inclisiran. It's a very strong drug. It can lower the LDL cholesterol by about 50%. And as mentioned, it can be prescribed both by primary and secondary care physicians. There are a lot of research studies ongoing looking at outcomes. There are some outcomes, but we don't yet have quite the outcome data, perhaps for statins and for some of the other medications. The other injectable therapy are PCSK9 inhibitors. And these also act to reduce the effect of PCSK9, and that leads to more LDL receptors. And that, similar to Inclisiran, means more LDL is taken up into the liver, and you lower your cholesterol. There are two agents that are available, alirocumab and evolocumab, and both of these are given by fortnightly subcutaneous injections. And these have been around a while now, and both manufacturers have set up home delivery and patients to give their own injections. So it doesn't require a lot of primary or secondary care input, although it does require follow-up. And they're really probably the most powerful lipid-lowering agents around, and you can get perhaps a 60% reduction of LDL cholesterol in the clinical trials. They work very well with statins and synergistically with statins, and certainly they can be given instead of statins for intolerance or on top of statins if levels are not achieved. As Sue mentioned, the main role is in managing familial hypercholesterolemia, where you get really very high levels of cholesterol, but they also have a role in secondary care and in secondary prevention for patients who are not hitting target but have already had cardiovascular events. Currently, both in Lancashire, South Cumbria and Cheshire and Mersey, they are red coded, so they have to be prescribed by the hospital. These are the guidelines. I've listed it in a bit more detail than Sue, but essentially at the top, we've got for non-FH patients. If they've not had cardiovascular disease, you shouldn't be offering PCSK9 inhibitors. If you have had cardiovascular disease, if you're classified as high risk, which basically means one event, if your LDL is persistently above 4, you can prescribe. And if you've basically had 2 events or events in 2 different territories, if your LDL is above 3.5, you can prescribe. For FH, if you've got heterozygous FH, which is much more common, then if your LDL is above 5, you can prescribe. And if you've had any cardiac event, if your LDL is above 3.5, you can prescribe. But again, they'll need referring to secondary care for this. The newest agent is icosapent ethyl. It's essentially a stable ester of omega-3 fatty acids. It is 4 capsules a day, and it's only licensed for secondary prevention or for diabetes with at least one other risk factor. Patients have to be on statin therapy. There's very limited LDL ranges where it's allowed. And it does lower triglyceride levels, but really the theory is that it reduces events. And there is published data in New England Journal of Medicine of improved outcome on this agent when combined in high-risk patients on statin therapy. And this can be prescribed both in primary and secondary care. So the last condition to talk about, which is very, very important for us to think about, is familial hypercholesterolemia. As mentioned, the initial NICE guidelines were from 2008. They do update things on the website, but we would probably need a new guideline, hopefully at some point. As Sue mentioned, it's very common. We don't know precisely, but it's probably somewhere between 1 in 300 and 1 in 500 people in the UK are heterozygote for familial hypercholesterolemia. It's very, very often undiagnosed. There's a slightly old data here, but certainly when they asked lipid clinics how many patients do you have with FH, there was about 15 to 20,000 people known, and there should be more than 120,000 people. So the vast majority were not diagnosed, were not known. And it's a horrific condition, undiagnosed and untreated. On the right, we can see very old data of natural history for FH. This will be clinically diagnosed. There weren't genetic tests then, but for clinically diagnosed FH for men, by the age of 70, everyone will have had coronary heart disease. And for women, by the age of 70, 3/4 will have had a coronary heart disease event. High cholesterol for a long time is bad. So how do you diagnose it? Well, essentially the recommendation is to look at cholesterol levels and look at family history. So you're looking for genetic links and high cholesterol. So please consider it, and we'll come to Simon Broome in a second, for anyone with a cholesterol above 7.5, but especially if there's a family history of heart attacks under the age of 50 or under the age of 60 in first degree relatives. The advice is to use the Simon-Broome criteria or the Dutch lipid score, and we also can use the Welsh score, which is an adaptation of the Dutch lipid score. If you will have heard that tendon xanthomas and xantholamas are very common in FH. It's not that common, and their absence certainly does not exclude this diagnosis. We're happy to take referrals from a single LDL measure, which is a fasting measure, and it does require a fasting measure for LDL. But ultimately, before absolutely saying you've got this likely genetic problem, we do recommend even a second test to see where we are. So the Simon-Broome criteria are essentially for, on the top, definite FH, and at the bottom, possible FH. Definite FH if the cholesterol is above 6.7 or LDL above 4 in someone under 16, or cholesterol above 7.5 or LDL above 4.9 in adults, plus xanthomas in the patient or first degree or second degree relative, or genetic tests that are clearly abnormal that are linked with FH. And possible FH is the same cholesterol cutoffs and either a family history of a heart attack below the age of 50 in secondary degree relatives or first degree relatives under the age of 60, or a family history of very high cholesterol levels, namely above 7.5 in adults or 6.7 in children. I've done a few images of what xanthelasma looks like and xanthomas look like, and there are different sorts, but these are really quite rare. I think we've seen only a few in our lipid clinic in the last year or two. The management of FH really starts the same as the management of cholesterol for all people. It's statins and ezetimibe. The target, as Sue said, is actually no longer an HDL target, or non-HDL, sorry, cholesterol target, an LDL target. And there's a reduction of 50% of LDL. And we would recommend referral to lipid clinics if we're not hitting target for making the diagnosis. And we now have commissioned genetic testing and for consideration of more aggressive therapy. People from the age of 10 can be referred to pediatric specialists or pediatric FH specialists. And please, if they're at risk of coronary heart disease, do consider a lipid referral or even a cardiology referral, certainly if they've got established coronary disease, family history, or multiple risk factors. So finally, I thought I'd mention some of the secondary care lipid services that we have. We do have lipid clinics in Lancashire, at Blackpool, at Lancaster, at Preston and East Lancs. I can talk about the lipid clinic at Blackpool, which I set up in 2018. It's grown gradually over the last 4 years. Initially, we were able to see one clinic a month. We're now seeing 4 or 5 clinics a week, and we have a weekly MDT. We've got an advanced nurse practitioner who's trained in genetic testing and counselling and seeing patients. We've got 2 cardiology consultants, a cardiology pharmacist, and we're about to have a part-time clinical academic biochemist join us. We're interested in seeing, obviously, high cholesterol, high lipid issues, but we're very interested in diagnosing and managing hypercholesterolemia, and we tend to recommend the Simon-Broome criteria, so a cholesterol above 7.5 and a family history of a heart attack at a young age. We'll see anyone with very, very high unexplained hyperlipidemia, whether they've got a family history or not. So we're talking cholesterols above 9, or LDLs above 6.5, or non-HDLs above 7.5, very high fasting triglycerides, but please do check their thyroid function and alcohol history. Diabetes can be another cause of very high triglycerides. And we're also keen to see people with secondary prevention issues, especially if they're statin intolerant or their cholesterol levels are high and PCSK9 inhibitor thresholds are reached. We would like some general biochemistry for blood count, liver function, thyroid function, and fasting lipids, because a lot of the advanced lipid therapies do require LDL, which requires a fasting test. A quick audit of the people we've seen. So in the last 4 years, the average age is about 55. The average peak cholesterol is almost 9. So it is really people with high cholesterol, but the range you'll see is from 3.1, which I think was a family history, was a cascade test, but essentially 5.5 up to 20. And the vast majority we see have got very high cholesterol levels. We do genetic testing now, and it's been commissioned across the Northwest for the last, I think, 18 months now. we've got 3 scores we can use: Simon Broome, Dutch Lipid score, and Welsh score. And the first 110 cases, I think that's our first year of testing, of patients who were referred for possible FH, we've picked up 16 cases of FH, a 15% pickup rate. And for those family members of patients where you expect 50-50, but I think we've probably been referred slightly more people with high cholesterol, the pickup rate's approximately 40%. So there's 26 patients we found. There's a lot more to go. I've got a little quiz at the end. We can't see you. I think we should have said that at the beginning. So we're talking to a blank screen. I'm sorry we can't see the audience. And I can't hear you either. But I think it's good just to see what we've heard today and to see if we've learned anything. So I'm going to go through a few questions, shout out the answers, and then you can see if you're right. You don't have to tell me how many you got. But this really covers what we've said today. So the first patient is a 45-year-old man with diabetes, hypertension, total cholesterol 6.5, LDL 3.2, HDL 1.0. So we'll have had a fasting test. Do people have any idea what the QRIS2 score would be? And I would normally say less than 10, 10 to 20, 20 to 30, or more than 30. And I've asked this of many people, and there is a range of answers, but the answer is 17%. So it is in the 10 to 20% range, so it is more than 10%. And so my next question is, what initial lipid therapy would you recommend? And we've got none. We've got atorvastatin 20, atorvastatin 80, alternative statin, and if so, which? Statin and ezetimibe, or something else. So I'll just give you time to think about that. Although I know you're immediately going to go to the answer, and the answer is atorvastatin 20. So that's very much in the primary prevention guidelines in diabetics with a high QRIS2 score. Case 2 is a 55-year-old man with hypertension, diabetes, previous heart attack, and peripheral vascular disease. Again, has had a fasting lipid profile. Cholesterol is 5, LDL is 2.8, HDL is 1, and is on simvastatin. And would you recommend any changes in lipid therapy? And we've got none. We've got change to atorvastatin 20, change to atorvastatin 80, something else, change to another statin, or something else. And the answer is atorvastatin 80. So we know for secondary prevention, they've had a previous MI, they've got peripheral vascular disease as well. Atorvastatin 80 is what we want. We want a non-HDL cholesterol target of about 2.5, which in this case we haven't achieved. We want an LDL target of about 1.8, which again we haven't achieved. And so we need to think about better lipid lowering. Case study 3 is a 62-year-old lady who smokes, who's got hypertension and has got angina. The baseline LDL cholesterol is 4.2. She's on simvastatin 40, but experiencing muscle pains, and she said, I can't keep on the simvastatin. And remember, simvastatin maybe is slightly worse than the others for muscle pains. So what alternative lipid lowering therapies might you consider? And so we've got cholestyramine, nicotinic acid, fenofibrate, omega-3 fish oils, alternative statin or lower dose statin, ezetimibe monotherapy, and there might be a hidden answer that you might want to think, have we missed anything out or other considerations? So any thoughts for that? And the answer is, so I've chosen both, and we could have discussions. I think we could certainly talk about an alternative statin, a lower dose of statin. I think that's the first thing to do. If they've tried lots and lots of statins and they can't tolerate statins at all, then we're now talking about ezetimibe monotherapy, and we're looking at other therapies for statin intolerance. We've seen the pathway, but I do hope you all said number 7, which was measure CK levels. So if anyone's getting significant muscle pains that have to stop statins, we need to make sure that there isn't any inflammation of the muscles that needs careful consideration. So the fourth one is a 47-year-old male smoker who's been discharged on atorvastatin 80 after a recent non-ST elevation MI. They've had a stent. The father died of a heart attack at 51. cholesterol 6.1, LDL at 4.2. What might you advise? And the options I've given are omega-3 fatty acids, ezetimibe 10, alternative statin, if so what, and something else, if so what. So have a little think. And I hope you've all said number 4, something else, if so what. And the first thing to do is check that he's taking his tablets, because the most common cause for failure is that they're not taking tablets. And if they are taking their tablets and they've still got such high cholesterol levels, they could have FH with that family history, and they certainly could consider therapy with a PCSK9 inhibitor with the LDL of 4.2. So please do refer to your lipid clinic. So my final case study, number 5, is a 55-year-old man with hypertension, previous heart attack, and CKD. Baseline total cholesterol is 7.6, HDL is 0.9. I've put an LDL down, but maybe you don't have that. And so can you calculate the non-HDL cholesterol? So we've not told you how to do that. You should get that in your results. But how do you measure, calculate non-HDL cholesterol? Well, you take 7.6 in this case, and you subtract 0.9, so it's your HDL off your total cholesterol, and that will give you 6.7. So that's the non-HDL cholesterol. Patient was started on atorvastatin 40. This was reduced to 20 because of muscle pains, and they tolerated that. And these are the results: an LDL cholesterol of 3.9, total cholesterol of 5.7, HDL of 1. And so this, then we measure the reduction in non-HDL cholesterol, and I can tell you it's a 30% reduction, so it's not easy, but this person's got a 30% reduction on HDL cholesterol. What would you recommend? Would you recommend no change, up titrate to atorvastatin again, change to rosuvastatin, add ezetimibe to the atorvastatin, consider FH and refer if there's a family history of ischemic heart disease, and consider Inclisiran after adding in ezetimibe if ezetimibe doesn't work? So I've given the game away a little bit because it's the last 4. I think what we should do in this case is have a good response, 30% reduction, but not quite 40%. And then ezetimibe, I'd think about FH because the initial cholesterol was 7.6, so it would fulfill that cutoff. And I'd consider Inclisiran in this patient if we don't lower the LDL cholesterol sufficiently. It's 3.9. If it stays raised above 2.6, it would fulfill the criteria for ezetimibe. So learning points from today. I hope you've come away with some learning. We'll do that questions and answers for the last 15 minutes shortly. But essentially for primary prevention, it's atorvastatin 20. For secondary prevention, it's atorvastatin 80. But please also remember FH. You're aiming for a 40% reduction non-HDL cholesterol whenever you start these statins, except for FH when it's a 50% reduction in LDL cholesterol. Please think about ezetimibe and the statin intolerant pathway for people who can't take statins. Please remember that there are lipid clinics out there, and we can offer a lot of help and support. So thank you very much.